Good afternoon, everyone. I would like to thank the organizers of AIOS and Dr. Swaroop for this opportunity. Dr. Swaroop very clearly mentioned that cataract surgery post radial keratotomy is somewhat important in the current scenario because we have a subset or a cohort of patients who have undergone this particular surgery about 20, 30 years back during their 20s and are now developing cataract. So a few approaches to tackling this condition is what we will be looking at in the next few minutes. So we all know as anterior segment surgeons, cataract surgery is the bread and butter of our day-to-day life. But what happens when you're faced with different kinds of breads and different kinds of butter? So that is when you kind of get into a conundrum as to how to handle them. But like all the speakers before me also very eloquently described, putting together the pieces of the puzzle together can lead to a happy patient and in turn a very happy surgeon as well. So one such situation is cataract surgery post radial keratotomy. Like you can see in the image over here, this is a patient who has undergone RK many years ago and has now come with a scarred cornea with multiple incisions. So the immediate tendency is to refer this to a cornea surgeon if you're practicing only cataract surgery, but with the help of certain precautions, it can be done safely in any setting. A little bit about radial keratotomy. It was a refractive surgical procedure to correct myopia and was developed in the 1970s by Yodorov, who was a Russian ophthalmologist. It practically contained 6, 8, 16, or 32 deep stromal incisions that were made in the cornea with the help of a diamond knife. So these incisions had to be at an 80 to 90% depth to achieve their intended outcome, where because superficial incisions are less effective than the deeper ones. So how RK evolved was in the beginning it was generally done from the periphery to the center, and later it evolved to moving from the center to the periphery. So at the current scenario we are in, we know that incisional refractive surgeries have lost their favor due to the variety of post-operative complications that were noted in these patients, and laser refractive surgery have gained popularity. So some problems that are peculiar to incisional refractive surgeries and their subsequent management are what we'll be touching on. So the specific challenges post RK are the refractive surprises that you see, the challenges in IOL power calculation, and some modifications that are needed in surgical technique. Refractive surprises occur because during the night time when the eyelids are closed, the incisions get hydrated, which leads to a hypermetropic shift in the early morning. And as the day progresses, you will see that the patients gradually become myopic. So even in the patients post RK, you will notice this diurnal variation in their refractive error. So a landmark study that looked into this phenomenon is called the PERC study, which is a prospective evaluation of radial keratotomy eyes. And they followed a cohort of patients for up to 10 years post surgery. And if you notice here, they mention very clearly that a shift of the refractive error in the hyperopic direction continued during the entire period of 10 years after surgery, which is quite significant. This brings us to the second challenge of IOL power calculation. So this simple diagram depicts the main difference between laser vision correction and radial keratotomy. In laser vision correction, because only the surface is getting ablated, you have a flattening of the anterior cornea, but the central optical zone remains wider on the posterior aspect. Contrast this to post RK, because due to the incisions, you have a flattening of both the anterior and the posterior corneal surface, which leads to a smaller central optic zone. So what does this essentially mean? If you look at the diagram on the left, you will see that the effective lens position in relation to the anterior corneal curvature in an eye pre-radial keratotomy. Contrast this to the picture on the right with an eye post-radial keratotomy, where there is flattening of the anterior corneal surface and a subsequent change in the curvature of the anterior and the posterior corneal surface in the paracentral 3 to 4 millimeters zone. So this leads to expected problems in the biometry of such patients. So this is an A scan, which is a lens star of a patient who has undergone radial keratotomy. So if you look here, you have very flat K values, and the axial length is also very high. So how do you choose the IOL formula? Traditionally, A Barrett True K formula is recommended even in the absence of your knowledge of the pre and post RK values. The True K formula uses an algorithm which gives you an accurate prediction of the IOL formula. In addition, it is essential to do a pentacam in these patients where available. A pentacam gives you accurate information about the areas of scarring and excessive flattening of the cornea. And like Dr. Vineet already mentioned earlier, the EKR holiday map is an additional feature that is seen in a pentacam. So this, if you look here, it compares the K1, K2 values in all the different zones of the cornea from 1 up till 7 millimeters. What we look at in a post-RKI are the K values in the central 4.5 millimeter zone, which are then used for calculation. These K values are then inputted into the ASCRS online calculator, which is an easily available online resource. So after you enter the basic details, even if the pre-RK data is not known, the basic post-RK data, which is derived from the pentacam readings, the axial length, the anterior chamber depth, and if present, any of the other information can be entered. The formula works in such a way that the more details you input, the more accurate the IOL power is obtained. The calculation is then done using the Barrett-True-K formula. You get an average IOL power and also a variation of the minimum and the maximum. A preoperative evaluation of the patient before taking up for surgery is important, which includes a slit lamp examination to look at the number of cuts and the space between the incisions, and an anterior segment OCT if available to look at the depth of the cuts and the extent of the scarring. So this is a surgical video that I will take you through the different considerations in an RK surgery. So if you notice here, it is preferable to do it in retroillumination. A retroillumination gives a very good glow of from the fundus, and you can visualize the areas of the cuts very clearly, and also any possible areas of scarring that you can avoid. Always make the entry through the area of the clear stroma in between two cuts to avoid any risk of dehiscence. A scleral incision is generally preferred in RK corneas which have more than 6 to 8 cuts, because you want to avoid causing dehiscence of any of the wounds. So anything more than 12, 16, go ahead with a scleral incision. A careful scleral incision is made, and once you go ahead with your regular hydrodissection, a phacoemulsification can be done. Care must be taken to use low flow settings during phaco, because you don't want to put additional pressure on the cornea, which in turn can cause any dehiscence or opening up of the wound. The choice of IOL is always tricky in these patients. One must remember that post-RK, the amount of spherical aberrations increases phenomenally. So prefer a monofocal aspheric IOL. Multifocal IOLs and toric IOLs should be avoided. And in all cases, it is preferable to suture the wound. The side put need not be sutured unless you are suspecting a leak. So to summarize, if you are planning a corneal incision, like I said, only in 8 cuts or lower, prefer to use a 3.2 millimeters for 8 cuts and 2.2 for 12 or 16 cuts, but prefer a scleral incision in the early cases. The target refraction is something that one should keep in mind. So because these patients are expected to have a hyperopic shift, aim for a target myopia of minus 0.5 if you have an 8 cut RK, minus 1 for 12, and minus 1.5 for 16 cuts. And the post-operative refraction must always be counseled to the patient that it stabilizes only after about 3 months. Limbal relaxing incisions are not recommended in these patients, and an option of an RGP lens or a piggyback IOL can be given later. So one of the most dreaded complications in an RK surgery is a wound dehiscence during surgery. So if you look at this surgery over here, you will notice that there is a giveaway of the wound at the site of the main corneal incision. This is probably because the surgeon made the incision too close and should have preferred a scleral incision in this case. So once the wound has opened up either way, there is no purpose in making another one once the phacoemulsification is completed. So go ahead, and the IOL was placed over here. This is a 3-piece IOL that was used, and it is carefully dialed into the bag. Make sure that all maneuvers are such that you do not cause any further trauma to the wound. So if you see during the washing of the viscoelastic, there was egress of fluid through the wound. So this diagrammatic representation on the right will show you that if you try to pass a suture through the red line, which is the wound that has given way, this causes excessive pressure on the adjacent incisions and can cause them to open up. So what the surgeon is doing instead is passing a single long suture that covers not only the wound that has given way but also the wounds on either side of that wound. This causes better tectonic stability, does not cause opening up of the wound, and then the knot is carefully buried. So once the suture is passed, it's tied and it's carefully buried to avoid further trauma. The scleral incision is also sutured. And if you see now, during removal of the viscoelastic, there is no further leak. The side ports are then hydrated. So wound dehiscence, although quite alarming during surgery, can be carefully managed with the help of simple suturing techniques. So to summarize my talk in a nutshell, most important in performing cataract surgery in post-RK patients is to do an in-depth patient counseling about expected refractive outcomes and possibility of further surgeries, a detailed preoperative evaluation including investigations and adequate biometry is needed. Always prefer a monofocal aspheric IOL in these patients. Anticipate and be prepared for wound-related complications. Always keep your suturing set on hand and expect post-operative refractive surprises for up to 3 to 6 months post-surgery, and best not to intervene in the immediate period and allow the refraction to stabilize before planning a second refractive procedure. Thank you for your patient listening, and I'll be happy to answer any questions.
Thank you for a
Thank you.
wonderful talk.
I have a question. They have many of these RK patients actually get very good refractive outcomes and they come near emmetropic and they're used to being spectacle free. So after RK, sometimes they want spectacle independence for near also. So there have been some reports or discussions about people using EDOFs. I do agree that using a multifocal or a trifocal is probably not a good idea because there will be irregular astigmatism. But do you think it's reasonable to think of an EDOF in these kind of eyes?
So again, depending on the number of incisions on the cornea, so we know that the more the incisions, the higher the amount of spherical aberration. So if there's a way we can quantify the spherical aberrations and then explain to the patient in a way that your aberrations will be corrected only to such an extent, you would still have a happy patient. But if they are expected to pay an extra amount for a suboptimal outcome, it depends on balancing the two, I would say.
How about monovision? Monovision.
Because they have these fluctuations throughout, even post surgery, monovision requires an expected exact outcome. You should be able to identify which is the eye that is going to have 20/20 versus the eye that is not, and RK is generally bilateral, so both eyes are expected to have these fluctuations. So calculating and giving an accurate monovision would again be challenging.
I think EDOF is a very good suggestion, and actually, the challenge would be in finding the target refraction, because for EDOFs we are going for emmetrophy or even the first plus power. So
Yeah.
in this case, when we are targeting -1 with 16 cuts and also minus 0.5, so which power to choose can be a little tricky. In
So among all the methods that you are using for post RK, which do you think is the most accurate for getting more spot on results?
So I would recommend the one that we spoke about in the presentation, a combination of the Lenstar and the Pentacam, and use the K values from the EKR holiday map, input it into the ASCRS calculator, and then get the average IOL power and undercorrect for the expected residual myopia that you plan for the patient.
we have one.
Yes, sir.
Yes.
I have a question.
Actually, they are not questions. It's kind of like an impression from my work. Number one, in order to decrease the refractive surprise, I noticed that whenever I go high with my bottle height, because these are kind of like potentially opened incisions. So whenever the bottle is high, or if you're working with the Centurion, I have no financial interest, but if you're working with the Centurion or you're raising the pressure, this means that there is potential pressure which opens the incisions and makes the refractive surprise higher than we expect. So it's advised in order to keep the bottle as close as possible from the patient's head in order to decrease this potential pressure and opening of the incision. This is number one. Number two, regarding the incisions, the sutures which you take if the incisions are gaping, well, you said that you take the suture, but this suture will induce traction over the adjacent sutures, incisions on both sides. And in order to decrease that, before taking the suture, induce stromal hydration on the sides of each RK incision. So whenever you take the suture, the tightening will be over the edematous edges, so this will decrease the effect over the incisions. Last one, sometimes no matter what you do, you need to do pinhole pupilloplasty in order to decrease the higher order aberrations and improve the vision in those with very high corneas. Thank you very much.
Thank you. Those are very good, valid points. Well taken. So we have about 15 minutes and we can discuss the other scenarios which have not been covered in the talks. I think one of the important ones is the compromised endothelium, you know.
Yes.
We often have patients who have gateta, ranging from just simple gateta to you have some amount of edema in the stroma, but the epithelium is not edematous, to full-blown epithelial edema, which is almost with bullae, etc. So how does one decide whether to do just a cataract surgery or go ahead and do a triple procedure? What is your approach, Vineet?
This is a very important area, and I think if we are able to diagnose Fuchs disease well in advance, maybe usually it will be around the age of late 30s or even early 40s, and even if the cataract grade is it's say NO1 and C1, in these cases usually the Fuchs cataracts will have a good endothelial reserve in the periphery. So, in such a scenario, I would still wait, and if the corneal condition is well advanced, you can get away with just an EK. But what is very important is in the first visit to get a biometry done, because eventually the patient will land up in corneal edema, and that is not going to allow you to get a good K readings. So, in any Fuchs cases, I think it's a good practice to get a biometry done in the first visit itself. That can help you do cataract surgery at any point of time later. But any nuclear opacity, maybe of more than NO2 or NO2 NC2, and if the patient is not likely to follow up, and if there are if the patient has early symptoms, I think I will go ahead with a triple procedure.
The principle that I follow is if I'm seeing any clinical edema on the slit lamp, which means that the central cornea is as thick as the periphery, or if the patient is clear cut giving a history of morning blurring of vision, or I'm seeing some other surrogate signs of edema like Descemet's folds, etc., that will push my decision more towards doing a triple procedure. And in terms of, I don't think endothelial count is important, but I think the pachymetry value, if it exceeds 650, I think that for me is the threshold to think about a triple procedure. If it's less than that, then I try to do a cataract surgery alone with, of course, uh, the appropriate OVD and
Yes.
endothelial protective measures. Anything to add, Kavya?
Also, the staging of the fuchs, if you have dense, confluent central cuttae, even if you don't have that much of clinical edema, but you know that these are the patients who are going to decompensate earlier. So the option of a combined surgery can always be discussed with them, and the call can be taken whether to do it sequentially or combined. And because we have such good refractive outcomes post DMEC, almost emetropia, so patients who cannot say undergo two surgeries can always be given that option based on our clinical examination of dense central gut.
What about DSO or DWEC?
So we know that the visual recovery is much more prolonged in these patients, especially when combining with cataract surgery. So patient has to be counseled very extensively about that, and I would do the corneal procedure first and look at the outcome, and then if needed, if there is not sufficient clearing, you could combine it with endothelial keratoplasty and cataract uh, subsequently.
I think a good option here, in especially when the corneal signs are more and the cataract has not developed in Fuchs, is you can try ripasudil or nitarsudil like drugs, because they usually work on the endothelial reserve in the periphery, and that will help you buy some time to anticipate if you can do a triple maybe in a few months' time.
I've used in many such patients. I don't really find it very useful. I think you have to remove that unhealthy endothelium to allow the peripheral reserve to kind of work. So that's why I was asking if it might be a good idea to try that first and see if the cornea clears up.
I agree, doctor.
Another very common situation that we come across in our clinics is a pterygium with a cataract, and I think all of the cataract surgeons would be facing that. So, what are your thoughts on patients who have significant pterygia, or how do you decide that a pterygium needs to be addressed, or you just do a cataract surgery? What is your decision-making tree?
So, if a patient is presenting with anything more than a grade 2 pterygium, which also you have to do an A scan preoperatively, and if the astigmatism is more than 2.5 to 3 diopters, then prefer to do a pterygium excision first and wait for at least 6 weeks before planning cataract surgery. Also, avoid a toric IOL even for the residual astigmatism later, because corneal scars do tend to remodulate over a period of time. So, any difference of opinion?
So for me, over time, what I have realized is sometimes even a very small grade 1 pterygium or something very atrophic in the periphery, which normally we would not have given too much importance to. If you start looking at the topographies, many of them have some irregularities coming all the way to the center of the visual axis. So I just in every pterygium will do a topography, and if I see any irregularity in the central cornea, I will try to address the pterygium either primarily or along with this procedure if I'm not using a premium lens.
I usually avoid doing combined procedures on, again, for the same reason, because I the pterygium is more than what you actually see. So definitely the
So what
topography
happens is
changes.
central to the pterygium itself, you have a tear lake, and
Yes.
that also causes a lot of
Yes.
irregular astigmatism, and
Yes.
that sometimes can cause quite a bit of astigmatism.
On the
Also, a question to be that many people do face is doing the pterygium surgery at the same time or doing it sequentially. If
So I used to always do what Vineet said: first do a pterygium and then wait 2-3 months and then do a cataract surgery. The problem is, practically, it's very difficult for many of our patients who don't want to come back again for a second procedure, especially if they are having bilateral cataract with pterygium. It means they have to go for 4 surgeries. So it doesn't always work, and when we have outstation patients. So I've started doing a combined procedure in many of these pterygiums, and I proactively counsel them for a monofocal lens. Even if you have a lot of astigmatism being induced by the pterygium, usually the spherical equivalent of the K remains the same. So it doesn't really affect your spherical results so much. So if you're going for a monofocal lens, I think it's reasonable. And I have now started doing more and more combined procedures because more for the convenience and logistical reasons, and it does work well.
we also face situations of patients, especially who work in very bright sunlight, agricultural workers who come in with spheroidal degeneration that causes a significant amount of astigmatism.
Yes,
So,
I think spheroidal
uh,
degeneration is a genuine
yeah.
problem, and
So
I
I
was,
think the
yeah.
question of again combined or sequential surgery is very important there, because if you tell these patients that you want to do it 4 times, most often than not, they're not going to agree.
Yeah. So I think spheroidal degeneration is something which is very, very common. And my approach to it is, if I find that it's not looking very significant or the visual axis is relatively spared, I'll often just do a cataract surgery first, because many of them will reach 20, 30 or
Yeah.
so, and then they are pretty happy with it. So I would avoid touching it if I can. But if I feel that it's quite significant, then I will address that first with, say, a PTK or some sort of a procedure on the surface. and then wait for the surface to stabilize and then go for it.
For long-standing pterygiums and spheroidal degenerations, what I feel is that if any degeneration is very long-standing, it's better not to touch, because suppose the pterygium is atrophic and just sitting quiet for many years, I think it's not going to affect the keratometry any further. So in such cases, even if you leave the pterygium alone, it doesn't matter. And same in that case for spheroidal degeneration, if it is long standing, what I feel, my hypothesis is that there is some long standing insult to the ocular surface, and that is why there is an abnormal epithelial healing, and that is why that degeneration has happened. Now if you go and disturb that, you're going to invite another trouble with that the surface is not going to heal post op properly. And we have seen cases where these patients actually landed up in 10 days time with a corneal infiltrate because of exposure and epithelial defect not healing in time.
You're absolutely right. The spheroidal or salesman, all of these are healing responses to kind of fix
Yeah.
something which is wrong on the surface, and then you're disturbing that milieu, and it can end up in more of a problem. Sometimes less is more.
So in one of your videos where we saw for macular corneal dystrophy, we did a combined surgery. So oftentimes we see patients with granular dystrophy, which do not often require any intervention for the dystrophy, but are now presenting with cataract. So one is often tempted to tackle the cornea as well as the cataract at the same time. Uh, what would you
So I think most granular
suggest in that?
dystrophies don't really require a keratoplasty. Most of them can do well only with a PTK if you have a superficial variant. And those are the only opacities that really affect vision. So I think from the cornea point of view, we should be avoiding keratoplasties in granular dystrophies, because most of the time you won't get great outcomes or great difference unless there's something else along with it. So surface procedures like PTK, I think, are the way to go, or maybe a FALC. And cataract surgery, of course, uh, itself will address most of the visual problems in these patients.
I think a careful history in these patients when they have experienced the diminution of vision. So, if the diminution of vision is recent, you know that it is probably due to the cataract only, and they'll be happy after the surgery, cataract surgery alone without. Yeah, please go ahead.
Sir,
There's a question from the audience.
yes, yes. Sir, I just have a small query. While removing the pterygium, I found that if I use a burr, if I manipulate more, it leads to more scarring. We know it's a preventive procedure, but it's finally it also has a cosmetic factorial to it. So right now I don't do anything. After I remove the head and the body, I just see if there's any strands of degenerated tissue and I just remove it. And earlier, initially when I started, I just was using the burr or used to manipulate it more just to smoothen the surface. I was in a concept that if even a slight amount of heaping, it will cause some tear film dispersion, it will cause a breakup over there. But right now, I don't touch only if there is any very small irregularity, I just address it. And I use a 26 gauge needle bent over to dissect so that it's so flush to the surface. But is using a I found using a burr very detrimental, and also using a crescent blade up and down shaving also to be detrimental. Is it
So
in
the,
fact?
so the principle is you don't want to remove any unnecessary stroma as possible.
Yes, I feel that doing that it incites more
Yes.
inflammation, and I put him on steroids for 2 to 3 months based upon this response. But I just want to know, I'm not using a burr also, but I found a drastic difference in the scar how outcome post the pterygium, because any of this degenerative tissue is going to seep down inside the stroma and it's also going to cause a scar. Is it correct or?
So most of the time, I never use a burr. So I'm also
Okay.
with you. I just try to remove the pterygium as atraumatically as possible and try to just get the virgin stroma bare, which is possible in most cases. If you try to cut into the stroma with a crescent blade or something, you will end up with more of an irregular bed, which then the epithelium will have to grow over and compensate. So even if I'm using a blade, it will be perpendicular to the stroma so that you don't cut into the stroma.
You can use a needle, sir. Needle is actually.
You can use many things, yeah. There are different ways. Yeah.
But is it? Sometimes there are few strands of this.
You can leave them. You can just pick them with a forceps, and few small strands will not really matter. Over time, the epithelium will grow over and smoothen everything. Epithelium is your best friend.
And what about the slight heaping up, sir? That tissue is degenerative, right? It's going to be have a superior contour compared to the rest. But the literature says, if it's not smooth, breakup happens faster, it leads to dryness. But I've not seen those in my patients. So what should I,
No,
what's,
if you have some of the pterygium tissue, subepithelial tissue which is sticking there, it's definitely a good idea to peel it. But other than that, small fibrils here and there, whatever the big ones you can remove, and you don't really have to chase everyone and make it absolutely smooth. You don't even need to use a burr in every case. I don't think it's necessary. You can always do a PTK or something later if you need to.